It's time to get the story behind the story. Interviews with newsmakers, news breakers, and Vermonters making a difference. WCAX presents 802 News with Mark Johnson. Here's Mark.
Vermont lawmakers will try later this month to override Governor Phil Scott's veto of a bill allowing the creation of a drug overdose prevention center in Burlington. The governor said such sites are well-intentioned, but rejected the proposal as a costly experiment that would divert resources from proven prevention, treatment, and recovery strategies. The $1.1 million center would be funded from a settlement the state reached with drug companies several years ago. The legislature strongly supports the idea. It passed the 30-member Senate 21-8 and the 150-member House 96-35, with 18 members absent. Two-thirds support in both chambers would be required to override the governor's veto. Supporters say the site will not only reduce the number of overdose deaths, which has doubled in the past 6 years, including 231 Vermonters last year and a record 244 the year before. Supporters say the site would also reduce the burden on strained emergency medical workers and offer services to help addicts get into recovery programs. Among the supporters are Ed Baker, a retired psychotherapist who has counseled opioid users and is a former intravenous drug user himself, and David Mickenberg of the Drug Policy Alliance, one of many groups that supported the measure. In this edition of 802 News, sponsored by Red Hen Baking Company, they'll outline the reasons the center should be established. We start with Ed Baker.
I'm a person with lived experience of addiction. I lived a lifestyle involved with addiction for over 20 years. I injected drugs. I recovered from my addiction with the help from a lot of people, and I became a psychotherapist in Vermont. I had a 30-year career working with people with substance use disorder. I'm now retired, and I am an activist for overdose prevention centers.
Why do you think you used when you look back on it?
Well, my example is the example of many people with addiction. I had what would be called today, multiple early adverse experiences, early childhood adverse experiences, with no one to talk to. And I developed a very deep, dark inner world. We probably would call it adolescent depression. And I found drugs that helped me to feel differently inside. It was very innocent in the beginning, but it progressed to injection drug use. And I spent 21 years of my life virtually lost in drug addiction.
How did you get out of it?
It was a long process, multiple incarcerations, multiple coerced treatments, multiple attempts on my own, and finally I found a group of people who recognized me for who I was, placed no demands upon me, and gave me the support I needed to finally make that transition into recovery. I had been trying my best, believe me, with all my might for years, and finally, the forces just lined up, personal forces and structural forces and support forces lined up, and I did it. I think about it often because we died back then. We died of overdose, we died of violence, we died of AIDS, but it was nothing like it is today. We didn't have fentanyl and xylazine, and we weren't dying at the rate. I would have been dead for sure, absolutely, certainly, many times if I was using drugs today the way I used drugs then.
Before we get any further here, you made a request, which I am happy to honor, that we just take a moment here and reflect on this. And why did you want to do that?
I think it's important for us to reflect on those loved and loving ones taken from us by accidental drug overdose, because I think it's where we need to begin together. We need to face the grief we're feeling, and once we face that, we face the magnitude of what we're up against, and we join in that, and we rise up out of that connected and empowered to really do something about this. We can do something about this. So I'd like to begin just with a moment of silence. Thank you.
Why do you think this issue is so much more profound, deep today than it was back when you were using?
Well, I think it's morphed into a tsunami of accidental death. We died back then, but we didn't die like we're dying today.
Well, and now the drugs have changed too. It used to be heroin, then it was fentanyl, and now it's xylazine. I mean, it just sort of blows my mind. People are willing to inject themselves with a horse tranquilizer.
There's a phenomenon. This is a good question because it boggles the mind, and it doesn't line up with common sense. There's a phenomenon called supply shock, where consumers can only access certain supply. That's what's happened in America. Pharmaceutical drugs morphed into heroin, morphed into fentanyl, now has morphed into fentanyl and xylazine. It's all controlled by international crime organizations. It's cost effective for them to produce synthetic opioids mixed with xylazine, so that's what they market. And people on the street who use drugs cannot, there is no heroin left. You cannot get heroin in America today. So people on the street, a lot of them, many of them, with chronic unmet needs and with addiction, are exposed to this supply that's lethal, and they can't get anything else. That's why they inject it. And to make it worse, there's a new chemical, a new central nervous system depressant called medetomidine. I read a report yesterday, a federal watchdog agency just analyzed a number of multiple deaths in Philadelphia, Pittsburgh, and Chicago. This new central nervous system depressant is being mixed with fentanyl now, and it's characterized by extreme sedation and profound decrease in heart rate. So people are dying, in unprecedented numbers in this few locations. It seems the analysts are saying that the reason the cartels are doing this is because xylazine creates sores, and this particular central nervous depressant that they're using now does not create sores. So the people on the street using drugs, what do they know? They're going to buy whatever they can.
But go back, I asked you why people were using these. What is the hole in people's heart or wherever that is driving them to use these drugs?
Well, we have diseases of despair, they're called in America. We have poverty. We have racism. We have stigma. We have pockets of unemployed people across America with no opportunity. We have many, many thousands of people with chronic unmet needs. Look at the unhoused situation in America today. Then we have people who, people have been taking drugs since the beginning of time, who just take drugs to alter their consciousness. The international cartels now are producing counterfeit opioids, where fentanyl is involved in cocaine and methamphetamine. You can go out, you can be a person who goes to a party and someone gives you a little bit of cocaine and you can die from a fentanyl overdose. So there's lots of different reasons to use drugs. My career has been focused on basically with people with severe drug use disorder. That is the group that I tend to look to because I see them most at risk and most in need, and that's where I focus my time.
As you know as well as I do, it's not only the deaths that are involved in this, the impact is much wider than that. For example, I interviewed a number of EMTs who work here in Burlington. Yeah. This has greatly changed their job / calling. Yeah. I mean, they were going out on these calls. People are mad at them for bringing them out of a high. They're not able to respond as quickly as they'd like to people with other medical emergencies.
Yeah, I believe there's an intense stress, an intense underlying grief that our culture is suffering from today, and we're not facing it. We need to face it, and we need to do something about it. I'll tell you, one of the most impactful experiences I've had is to hug a parent who's lost a child to accidental drug overdose. We have Team Sharing Vermont, a group of parents in Vermont who have lost their children. And I'm in touch with them. I know them. I talk to them, and sometimes we hug. And when you hug a parent who's lost a child, you feel it. You feel it the way they feel it. And there's nothing that compares to it. And I think we're all feeling that sense of losing our neighbors, that sense of wanting to do something, and that sense of, frankly, being prevented from doing the most we can do. You mentioned early responders and emergency technicians, and the stress they face. An overdose prevention center would decrease that profoundly because people would have a place to go where they would find what I like to call unconditional safety. No demands, no judgment, no requirements. Just come in here and we're going to help you to stay alive. We are going to assume the responsibility for protecting you, the most vulnerable population in Vermont. In my view, overdose prevention centers really are the next logical medically necessary step.
Other people call it safe injection sites. I think we can probably use those terms interchangeably.
No,
why not?
No, we can't.
Why not?
Because I'll tell you why not. Because safe injection sites, that term elicits what's called implicit bias. People think of people injecting drugs, and that's all it is. When a safe injection site is really an overdose prevention center, there are some people calling them comprehensive user engagement services. They're places where people with severe drug use disorder or people who use drugs can go, be safe, begin relationships, learn about safer way to use drugs, be referred for additional health-promoting activities, have relationships. We're looking at a completely marginalized population. This is who's dying most. We see them. I've spent time in Kensington West in Philadelphia. I've spent time in the Tenderloin in San Francisco, and I've spent time in City Hall Park. And it is the same population, marginalized, disenfranchised, with chronically unmet needs, and many of them with addiction. This is who we have to respond to.
Governor Phil Scott has been opposed to these, David. So how and why are you involved in this issue?
I've been involved in drug policy reform since 1997, and then in Vermont since the early 2000s, working on issues. I mean, there was a time in Vermont, if you can imagine, things that seem commonplace and ubiquitous in Vermont around drug policy, where we had no methadone treatment, we had no buprenorphine, we had no syringe exchange, we had no hub and spoke, we had no naloxone treatment, naloxone. I've been involved in the policy development of those issues, and it's good to reflect back sometimes to realize when we talk about an issue like overdose prevention centers that many of these things that seem so commonplace and so understandably public health oriented didn't exist, and it took the energy and the advocacy of people like Ed and others that have been involved in this to make that happen. So yes, lobbyist, attorney, and drug policy advocate for about 25 plus years. This idea of harm reduction and meeting people where they are just had a really powerful impact on me. And I never really understood why we would place the judgments that we do on people for the behaviors that they have that impacts mostly themselves,
Okay, but at the same time, you can understand why some people would look at something such as needle exchange as not being the best public policy, right?
I have a hard time understanding that because I don't believe in the idea that providing people with clean syringes is facilitating or encouraging them to use. I think it's really a public health measure that helps them and maintain their health, but also helps the community. One thing you brought up around OPCs, one of the secondary benefits is around treatment of things like injection wounds. So one case of endocarditis which the hospital here has said there's been a 900% increase in infections related to injecting. One case of endocarditis at the hospital could be somewhere between $100,000 and $600,000 to treat. The economics are important to look at, but the fact is that if we can avoid things like that, it has a profound effect beyond just the individual. So I don't really see an argument in favor of not having clean syringes. And I think we've gotten to a point where we wouldn't argue, and we did hear this argument when we were the first state in the country to allow naloxone to be sold over the counter. We heard arguments in the legislature, well, won't this just allow people to be get really high and then be saved? And I said, well, just think about what you just said. Be saved. Yes, we want people to be saved, to give people a chance, to have people give people the opportunity to be able to live long enough to look at their lives and see if they want to make a change, or have the good fortune of somebody to come into their life and give them the type of love and access to services and resources that they never could imagine.
You look like there's something you wanted to add there.
It's funny that my emotion shows so much because David mentioned the word love, and David was the first person around here in my field that I heard mention the word love when it comes to responding to people with addiction. And basically, we don't talk about it, but this is a moral imperative, what we're facing here. We either turn our backs on this population and let them die because they are about to die, or we open our hearts and we embrace them and we spend the resources that we have on hand through opioid settlement money on creating safety for them so they can stay alive.
I can understand, just to backtrack, I can understand why people have a hard time wrapping their head around issues like this at times. I mean, we've been, whether it was the war on drugs, all the things we've heard, drugs are bad, this is bad, all of these messages have been encoded in me and Ed and all of us, and I understand why people's reaction, whether it's syringe exchange or OPCs, can be initially a hard thing to wrap their head around. I totally get that. And I found it interesting, actually, some of the political folks that have become the greatest champions started as major skeptics. Sarah George, for instance, we worked together 8 years
County
ago.
State's Attorney, yep.
Exactly. She admitted that before she looked at the research on this, she was a skeptic. Teresa Wood, the chair of the House Human Services Committee in the legislature, said before she looked at the evidence, she was a skeptic. Ginny Lyons said the same thing. Senator Ginny Lyons from Senate Health and Welfare Committee chair, who presented the bill on the floor, and Senator Phil Baruth, our president pro tem, all said it took time and really examining the evidence before they. So I understand the impulse. I think when we're talking about OPCs, overdose prevention centers, the evidence feels, at least to me, I think to us and to many in the legislature and in the public, overwhelmingly positive.
And I'm glad you acknowledge that, because I consider myself to be a pretty open-minded person, but it's hard to not have this initial thought that, well, will this allow somehow more people to use, that it will somehow make it less bad, for lack of that wasn't the most articulate way to describe it. And I understand, the Nancy Reagan just say no is absurd. The jails are packed full of people who, in some cases, are there for marijuana possession. That seems kind of absurd now. But on the other hand, I do know people that have stopped their addiction to whatever it is, alcohol, whatever, by kind of hitting a rock bottom and having kind of this moment where they have to make a decision. And sometimes that can be an arrest. Sometimes that can be being up in the emergency room at the hospital. And that's where I'm coming from when I ask whether or not these overdose prevention centers will not allow people to hit that rock bottom that they might need to. Mm-hmm. Maybe I can get both of you to comment on that.
Yeah, well, the unfortunate thing, and we were talking about this earlier in the drug supply, is that rock bottom for too many people is death, and so they don't get a chance. I mean, in the last over a decade, 1,500 Vermonters have lost their lives to overdoses. It's funny when Governor Shumlin was talking about the overdose crisis, cover of Time magazine and all that stuff, we were in the dozens of deaths that year. So I hear you, and for some people, this idea of rock bottom may be a helpful way to change their lives. I think the idea for overdose prevention centers is that when people maybe hit their low or want to change their life, there are people and resources there to help them do that, and most importantly, to help them stay alive.
The concept of rock bottom is kind of, I would call it an archaic concept. The fact that America had 111,000 accidental overdose deaths in 1 year should tell us a little something about rock bottom. Evidence shows that, to reach out to people, to engage them, to be aggressive about letting them know that we're here to help without judging them, about giving them safe places, shows that we can save lives. And I would prefer that to waiting for another 111,000 people to hit rock bottom this year. It's just we have to do everything that is at our disposal. The research has been extant for over 20 years that overdose prevention centers work. We now have 2 in New York City. We have 2 opening in Providence, and we'll have 1 in Burlington. The research so far in America is outstanding. On Point in New York has reversed thousands of overdoses, or hundreds of overdoses, has engaged thousands of people, has referred people for therapy. It has added, I think, did you mention the benefits to the community? People are understandably concerned about public drug use. An overdose prevention center drastically reduces the incidence of public drug use. People are understandably concerned about syringe litter. Overdose prevention centers drastically reduces syringe litter. The research shows this in America. You mentioned emergency personnel. Overdose prevention centers cut the stress of emergency personnel profoundly. There's cost savings in New York City, when there's a drug overdose, a detective and an officer have to be assigned to the case. It costs thousands of dollars for an investigation. Every overdose that's reversed, every death that's prevented in an overdose prevention center saves thousands and thousands of dollars. So the benefits to the culture are extremely profound.
2 other objections I've heard, 2 other concerns that I've heard is A, why would I want one of these in my neighborhood, number 1, and 2, won't it just be a place where drug dealers can almost have fish in a barrel, and they'll be planted right outside there and selling drugs to people? Well, you're both shaking your head on that one.
Well, in terms of the neighborhood piece, obviously community engagement is going to be important. Talking to people about what OPCs are is going to be essential for the success of this effort, and I have no doubt that that's going to happen. But the question I have is we had folks from the business community supportive of this. VBSR signed a letter. There was a public safety letter, actually, that went around, and I didn't agree with a lot of things in that public safety letter that went around in Burlington. But one of the things that they said, which is signed by all the business groups and is that they supported overdose prevention centers. I actually think that right now there are overdose prevention centers. They're just happening at the Fletcher Free Library, which the head of the library said in an article the other day, we are the overdose prevention center. I hope this bill becomes law. They're happening in restaurant bathrooms and other places. And so I think the argument in terms of why would I want it here? Well, it is here. It's happening. It's happening in an uncontrolled environment in which people are unsafe, and folks that have to care for them don't have the skills to do it necessarily.
Ben and Jerry's, Vermont, Ben and Jerry's, they had to close their public bathrooms.
Right downtown on Church Street.
Right downtown on Church Street, they had to close their public bathroom because the manager didn't want to expose his staff to the trauma of having to respond to overdoses. They closed their public restroom, but they came out with a public statement, and there's a little card in a little rack in front of the bathroom, and it explains why they closed the bathroom, and it says that they also, consider addiction a disease, and they feel compassion for people with addiction, and they support an overdose prevention center in downtown Burlington. That's an informed position based on science, based on compassion. They closed their bathroom, but they're not just saying, keep these people out of here. They're saying, we're not equipped to deal with this, but we're equipped to support the establishment of an overdose prevention center in Burlington. Now, I talk to a lot of people, even people opposed to an overdose prevention center. If you kind of tease out the reasons they're opposed and then have conversations with them about those reasons, many, many times one conversation will change their outlook, because people, like David alluded to, have been educated by the war on drugs, by stigma. We've been inundated with it since we've been born. When you begin to educate a person based in science and infused with compassion, they respond to that. The idea of discarded syringes, the idea of public use, the idea of emergency medical technicians. When you let people know what exactly an overdose prevention center does, they begin to soften toward it, because now they have some valid, current, science-based, compassionate information. And I think that's the work of our group. We really need to begin. We've been so involved with politics and getting this bill, where it should be, that we haven't had the energy really to educate the public. And I believe that's one of the things we'll be doing in the near future. I just want to say that one of the things that David touched on was the legislature, and he mentioned names. Now, I have witnessed that, and there were certain people in the House and the Senate who began to get interested in this and began to embrace science. And they opened themselves to testimony from researchers. And once they did that, they became convinced. And if you were at the House and the Senate hearings, you would swear you were at an addiction conference listening to experts. They did their homework, yeah. They knew what they were talking about, and they support this bill with all their hearts. And I think, and they're representing their constituents. I think we need to pay very, very close attention to what happens. We have the opportunity now to save lives. We don't have to see deaths occurring the way they are today in Vermont.
Can I just add one thing to that? The idea of this being sort of a sort of radical and untested concept that some people, critics have talked about, it's not true. There's been decades of research, decades of experience, but now it's in the mainstream of public health. The American Medical Association supports it, the Vermont Medical Association, a variety of public health organizations from across the country. And in Vermont, we had a community support letter that had over 500 names from 70 communities, 50 different organizations, all the leading harm reduction organizations, public health recovery groups. There's a real groundswell of support. I've been working on these issues for so many years that I'm still in the mentality that somehow this is sort of on the sidelines or fringe or experimental. It's really not. This is the mainstream, and we in Vermont are now hopefully and likely going to be embracing this mainstream public health approach.
We'll have more of our discussion with Ed Baker, a retired psychotherapist, and David Mickenberg of the Drug Policy Alliance in just a moment. First, a word from our sponsor. At Red Hen Baking Company, they believe pure, uncomplicated ingredients in the hands of skilled artisans are the building blocks for great food. They're dedicated to creating the best food from the best ingredients. You'll find an ever-changing lineup of delicious pastries, sandwiches, and soups at their beautiful cafe off Route 2 in Middlesex, just off I-89. Their breads are also available in many other locations. Led by owners Randy George and Eliza Kane, Red Hen Baking Company has been on the leading edge of the local food movement since 1999. Continuing our discussion with Ed Baker and David Mickenberg, who support creating an overdose prevention center in Burlington. Lawmakers will attempt to override Governor Phil Scott's veto of the bill creating the center when they head back to Montpelier on June 17th. I've read a little bit about this. In particular, there was a site in Vancouver. There's been some study and some work on that. It's clear that these sites reduce the number of people that die. But how effective have they actually been in terms of getting people help?
There's lots of statistics out there, but one of them, and I think it comes from the website opcinfo.org if people want to check it out. There's a lot of good materials there, but there's one statistic that says within 2 years of people utilizing OPCs, there's a 47% uptake on treatment, access to treatment services. In On Point in New York, 75% of the participants access some type of services in the OPC. So I do think there's evidence and increasing evidence that the common goal which is to hopefully get people stabilized in their life and healthy and in a place where they can feel like they are on a path toward whatever they're on a path toward, which is not sort of dangerous drug use. The evidence is that OPCs do accomplish that. So I think it's pretty clear.
Again, I would echo what David just said. My favorite definition of harm reduction has 3 parts. Harm reduction is an approach that's neutral on drugs, negative on harm, and positive on change. So this is the basis of what an overdose prevention center is all about. Neutral on drugs. You can come here and you can use drugs safely, and we are not going to judge you. We're not going to punish you. Negative on harm. We want you to harm yourself and the community less, and we're going to help you to do that. Positive on change. People have the wrong impression about harm reductionists. They think that we want, it's okay just to take drugs forever, no problem, just take drugs. That's not what we're about. People working in the field have what I like to call a third eye and a third ear, and they are extremely attentive to any sign of motivation coming from the person. That's the crucial part. If you're in my overdose prevention center and you're using drugs safely, you're harming yourself less. If you start talking to me about wanting to get on Medicaid or wanting to, seek housing or wanting to perhaps talk to a doctor about being on buprenorphine or methadone or anything that's changed, that's coming from you, not only me, but everybody in that center is going to be 100% right behind you immediately, and we're going to help you to change on your terms. This is what people in this particular disenfranchised category need most. The freedom and the dignity to make decisions at their own pace and have the resources available that are going to support them. And we don't have any outcome in mind. We're just there for you.
What about the objection that I raised that people are going to be concerned this will be a haven for drug dealers hanging around this site?
Let me tell you, I'm a person who used drugs for a very long time. I don't need a drug dealer coming to me. I don't need a drug dealer hanging out outside the Overdose Prevention Center. Any drug dealer hanging out outside the Overdose Prevention Center is really stupid because he or she will be arrested. I just think it's a total fallacy. Nobody is going to come here. People are not going to drive to an overdose prevention center. The statistics, the research shows, Brandon Marshall's study, the real area of improvement around an overdose prevention center is not big. It's maybe 6 or 7 blocks. After that, the benefits diminish a little bit. In Burlington,
I didn't understand what you just meant by that. What do you mean, the 6 or 7 blocks?
He did. Brandon Marshall, Dr. Marshall, did a study on overdose death around an overdose prevention center, and the deaths within a certain circumference decreased by 35%. No deaths in the center. Okay. 35% decrease in deaths around the center. So the people using the center were from a small circumference area around the center, maybe 6, 7 blocks. This is, if we just, I'm not looking at anywhere but Burlington. If we look at downtown Burlington, this is absolutely perfect. That's the catchment area. If you look at a heat map, it's bright as day, right in your face. We will save lives.
You know, as you talk about this, I think to myself too, you know, we have an upstream and a downstream problem where you're talking about catching people and helping them at the end of the process. Is it just naive for me to suggest that maybe we should be focusing the effort on what you talked about earlier, this just despair and loss of hope?
I think it's yes, and I think this is. I mean, that's the we've heard some arguments like we should be doing more treatment. Yes, we should be doing more prevention. Yes, we are. We are doing all of that, and we should be doing harm reduction services too. I mean, you look at and the way Ed described his path around addiction and substance use disorder. I mean, looking at the traumas that people have experienced in their lives would have massive impacts on where they ultimately end up. I mean, it's hard to access therapy in Vermont for people that have insurance and can afford it, let alone if you're on Medicaid or other, if you have a lack of resources. So mental health, stable housing, stable food and healthy food, all of these things that we know about, that is the upstream prevention tools in addition to messaging and things like that. But those are the upstream prevention tools that we need to invest in to make sure that this, that ultimately when somebody is at a point, they want to forget about their trauma or to have a feeling of peace, that somehow they're looking at various options to attain that.
What I'd like to add, though, which I think is relative and very pertinent, is the idea of, you know, the cost of prevention, the cost of education, the cost of treatment, and now the cost of an overdose prevention center. You know, this is something that we need to consider. And what I'd like to hasten to add and explain is that the funds that will be spent on an overdose prevention center are from the opioid settlement abatement. These are not general funds from Vermont taxpayers. These are funds that have been the result of a victory by T.J. Donovan and other attorneys general in America, a class action suit against Purdue, pharmaceutical distributors, and some other companies, some pharmaceutical chains. A lot of money will be coming into Vermont, and the reason it's coming into Vermont, tragically, is because of opioid deaths over 2 decades. The money is coming in to save the lives of people dying from opioid use. That's where we need to spend it, solely. In my opinion, every penny of opioid settlement money needs to be spent on remedies and interventions that are immediate and efficacious. Period.
Yeah, it's payback for past bad deeds, really.
Exactly. What pharmaceutical companies did to us, we're holding them responsible, and we need to spend the money on the populations most impacted. Now, that's not to say that prevention and education and school-based programs and those sort of things aren't important, but that money basically can come from cannabis taxes and other resources generated by the state. Opioid settlement monies need to go to harm reduction. I mean, how much more of this? I mean, really, this. I go back to the moment of silence. How much more of this can we take? How much more of this are we willing to take when we have research-proven interventions at our disposal, ready to go? Literally in Vermont now, we have every piece of the puzzle. We just need the willingness and the law to put them in place.
If you Ed mentioned moment of silence, and a couple years ago we did for Opioid Awareness Day, but also we had a press conference at the legislature, and we took a moment of silence at that time. I think it was 257 seconds, or right around that.
One
200
for every death.
Yeah, so 1 second for every death. And if you really want to feel the impact of this, set a timer for 250 seconds and sit in silence and imagine every second that goes by somebody's died.
I was at the podium, and when I opened my eyes, there were quite a few people that were crying, and rightfully so, because to feel that grief collectively is really what this is all about. And then to rise out of that, bonded by it, determined to do something once and for all, to not turn our backs on our loved ones.
What's been the most effective argument for lawmakers to turn them from a no to a yes?
I think it's really the evidence. I mean, I think when they're looking at the impacts of OPCs and the desire, like we've been talking about, to save lives. I mean, the floor debate on H-72 in the House was really very moving. We heard story after story of legislators who have been personally impacted by the opioid epidemic. And I think the fact that this has touched, that death associated with drug overdoses has touched so many people, I think people are at a point where they're saying, like, well, what more can we do? And this is something more which has a proven track record and evidence of effectiveness. So,
what's the one thing you would want to say to Governor Phil Scott if he were standing right here? What would you really emphasize?
Yeah, I mean, it's interesting. The governor, and I'm saying roughly 2017, said he would look at the evidence on this. And I would, if he was here, I would say, can you sit down with an open mind and just look at the evidence? We can look at all the evidence of arguments that not as effective and this and that. And I think, frankly, we saw that with the struggle of Dr. Levine, our Commissioner of Health, who has sort of gone back and forth and acknowledged their effectiveness, but in limited places and all of this stuff. I think I would really implore the governor, who's a compassionate and smart person, to sit down and look at the science, look at the evidence, and look at what the experts are saying. I mean, the American Medical Association, Vermont Medical Society, other places, and just make your decision based on evidence, not based on the old stigmas and the biases that we have.
And you think that's what it is, just that what we talked about almost at the beginning here, that kind of baked in feeling like, wow, really? This is the best way to approach this?
Yeah, I think, I mean, I've listened to a lot of his press conferences and his statements on this, and I've observed his career, and he's taken very courageous stands on some difficult issues, guns and other things. And I think this is one in which he sort of has a hard time imagining we are in a place in our society and in Vermont where this is necessary, and it's hard to get past that. And I would hope that he could get past that. And from his perspective, these other interventions, prevention, treatment, other harm reduction interventions feel like they're working, and that's the path. The disconnect that I have with him on this is that we have to get past the sort of notion that, yes, that Vermont has become a place where this many people die this easily, and if there are interventions, whatever they are, we need to have them. But I think it's really more the sort of, this is what we've become in our society, in our country, and in our state. And I think the reality is that, yes, we do need these types of interventions to save lives.
That wraps it up for this edition of 802 News, sponsored by Red Hen Baking Company. Thanks for listening.